Good morning, everybody. I am Dr. Keyur Parikh, Senior Interventional Cardiologist. Along with me are two other Senior Cardiologists, Dr. Tejas V Patel and Dr. Vipul Kapoor, who have been our partners for last many years. Along with us are Sunil, our Senior Nurse Technician. We have Priyanka and Manish, Senior Cath Lab Assistants. We have Joel, again Senior Nurse with us. We have today a very interesting case, a 60-year-old obese lady who has been my patient for many years, who last couple of years started developing resistant hypertension. She had an angiography, routine conventional, last year, which showed about a year and a half ago, which showed moderate coronary disease as seen in the slide. Along with that, she has had resistant hypertension, diabetes, obesity, episodes of diastolic dysfunction with heart failure, as well as sleep apnea syndrome. Last few months, her hypertension has become uncontrolled on 6 different medications as listed in the slide. Eventually, patient has agreed to undergo renal denervation, so she has been admitted. We have just completed non-selective renal angiography using a pigtail 15 cc contrast at 8 atmosphere per second. We can see both renal arteries very nicely with distal branches whose size appear to be slightly smaller than 3 mm. We'll be using Medtronic's Spyral Symplicity catheter, which allows us to ablate in 3 mm or larger arteries. So now we'll remove the pigtail and we'll introduce selective catheter to cannulate our renal artery.
So we are taking now RDC catheter to selectively engage the renal artery, and then we'll selectively wire one of the renal artery. It is again very important to use a non-selective shoot of the aorta, especially the visceral aorta, to look for the accessory renal arteries, which we also need to denervate if any accessory renal arteries.
The present catheter is about 115 centimeter long, so it cannot be used through radial access through conventional radial Judkins arteries, Judkins catheters, which are usually 125 centimeter long. Company is working into developing longer catheters. So we'll be using the renal direct catheter in this case. Her present blood pressure right now, with last medication taken last night, all 6 medication yesterday, is about 220 this morning. We have not given her morning medications just to ensure that during the procedure she doesn't get hypotensive or due to sedation. The intra-aortic pressure right now is 216 by 86. Mean pressure is close to 120. 140. So we have now cannulated the artery easily. We will take a short CV run with about 1.5 cc of contrast. Our baseline creatinine is 1.2. So we have a renal artery. The guide catheter is 6 French. So you can see the distalmost renal artery before the multiple distal branches is around 3 mm visually. Can we bring the screen closer a little bit?
Yes, sir.
And there is a large branch coming inferiorly before going into the renal cortex, but appears to be barely 3 mm artery. So if we go and ablate, we may just use 1 electrode at most, or maybe 2 electrodes. So now we are going to introduce through the RDC catheter our system. I'll have Vipul Kapoor and Tejas Patel show you the catheter and how to straighten the catheter and backload the wire. We'll be using slightly stiffer 0.014 Gansen wire in this case. You can use conventional wires. However, conventional wires sometimes do not straighten the tip of the spiral catheter as well. Tejas, why don't you come up and show the Grand Slam being introduced? Let's open up the spiral catheter.
Spinal catheter.
Patient is right now lightly sedated. Once we are ready to ablate, before that we'll sedate her much more.
So this is the Grand Slam wire, right, which is a 014 wire, but little bit stronger wire which gives good support to the catheter.
Let's open up. Yeah. We can open up the catheter.
So we will now show you the catheter now.
We can go ahead and start cannulating the renal artery.
So this is Medtronic Symplicity spiral catheter, and you can see the electrodes at the tip of that curved spiral catheter, which we will introduce over the wire, 014 wire, and that will go inside the renal artery and deliver the radiofrequency shocks.
So this is the catheter back end. This will be connected to the console there, which you can see, with which we will be giving the shocks of the ablation. There is also a remote here, which you can see either we can give through the console or through the remote. Alright. So this catheter will be back loaded onto the wire, and with the wire we have already cannulated the wire, as you can see. So which is going into the renal artery, the branches that we want to ablate.
So now let's load the catheter. Okay, let's get the SCT. SCT should be more than 250.
So we are now loading the catheter onto the wire.
Sunil, get the SCT syringe. So we have now the spiral catheter loaded on the Grand Slam wire, and we have the. So we are now pulling back the catheter straightener, electrode straightener, whatever you call it.
Yeah.
And you can see a straightened spiral catheter, slightly angulated where the electrodes end, slight 5-10 degrees angle, gentle curve, and we are now entering to the right renal selective artery. So we'll have to ensure that the electrode should be outside the cortex, outside the parenchyma. So we'll do a small dye shoot. I'll advance the catheter.
We'll go inside.
So we can go inside.
So we'll now assess, each electrode is 5 millimeter apart. So in this view, basically we'll be able to use only one active electrode, because the second electrode may come on the inferior large subsidiary artery. So let's go ahead and make sure, or we may be able to barely manage 2 electrodes. So we'll go with 2 electrodes first, advance the wire a little bit into the cortex, and then we'll go with 2 electrodes, give a small puff. So as a predicting, record the puff and freeze the puff. So only freeze. So we'll go a little further, because when we remove the wire, the spiral will kind of contract and foreshorten. So we are going still a little further, take a little squat again. It looks okay right now. We'll do a very small, very little dye cine run, very little dye, half a cc, to just make sure we are away from the cortex. So we are actually inside the, reasonably inside the kidney, right? Seen on the fluoroscopic view, we have properly placed the 4 electrodes in the spiral catheter, with the distalmost electrode proximal to the renal cortex, and the second electrode is facing the contralateral side of the inferior branch of the renal artery. The third and the fourth proximal electrodes are in the main renal artery. Tejas, why don't you show them the contact and the resistance?
Yeah, so you can see on the screen that the beautiful waveform, which is suggestive of very good contact of the electrode with the hole, which is showing the waveform and impedance as well. And you can see 1 to 4. The 1 is the distalmost electrode, and the 4 is the proximal electrode. We can selectively switch off or switch on the electrode whenever it is required. So we may plan to switch off the third and the fourth electrode because it will be overlapped later on when we withdraw the catheter and we again deliver the radiofrequency ablation at that time.
Overlapping has to be avoided. Vipul Kapoor,
Yeah.
why don't you turn off channel 3 and channel 4, the third and fourth electrode, show them, and then initiate the first ablation.
Right. So as you can see on this remote control, there are 4 you can say buttons. So as you can see, if I press this button, you can see the third one is switched off.
Vipul, before we start, just will ensure the acid is more than 250 or
Yes.
280.
Yeah.
So continue, please.
Right. So this is how we switch off the third and the fourth channels, and then presently we can keep it on, and then whenever we are ready, now you can see that the contacts are seen nicely on the screen, and whenever we are ready to ablate, then we can switch off the third and the fourth one. So,
The beauty of this spiral catheter is that it is non-obstructive. Since it's non-obstructive, we are not worried about occluding the artery or thrombosis in the artery. However, since the ablation will involve development of some degree of burn and heat, so adequate anticoagulation is required. Single antiplatelet is strongly recommended, mainly aspirin. However, patients who have had intervention before and are on dual antiplatelet, that is permissible. You do not need to stop the second antiplatelet agent. Before the ablation, the wire has to be pulled back into the guide. So we have done that. Make sure you don't pull the wire out of the proximal port of the wire. Otherwise, you will have to reintroduce the whole system once more again. So Dr. Vipul now has turned off channel 3 and 4 and he will start the ablation.
okay, so now I'm starting the ablation by pressing the RF button. So as you can see on the monitor, the RF is now being delivered. You can see the temperature and you can see the resistance as well.
Patient is reasonably sedated and she is very comfortable.
So the timer is already showing up on the screen. So roughly for about 25 seconds are done. So this is an AI enabled system wherein if there is any overheating or loss of contact, the system will switch off automatically, and that is very important for the safety of the patient. So roughly we do it for about 60 seconds, after which we will switch it off. Now it will switch off automatically. So now you can see the beeping sound and now it will stop. So that's done.
Now, Dr. Vipul, can you explain the 10% and 8% what is depicted in the channel?
So you could see on the screen that we showed a temperature rise of about 10 degrees centigrade and 8 degrees centigrade on the first 2 channels, which was because of the heat generated by the RF ablation.
Having done that, we have to ensure that we never duplicate the areas which has been ablated adequately. So now we are going to withdraw the catheter and to make sure that the distal electrode is slightly proximal to the carina. So now we'll check with the slide shoot. The guide is out, we'll make it with the guide. So as we see, we are in a perfect position. Why perfect? Distal electrode is at the carina slightly distal. But once we withdraw our guide wire, ground slab, there will be recoil in slight foreshortening. So it is very likely that the distal electrode will position proximal to the bifurcating artery. So now I'll pull the wire back.
We have the road name here.
Okay.
We can show the road map.
Record.
We just come back.
ACT While Dr. Tejas is flushing the system, acid is adequate. As you see in the fluoro run, can I have the fluoro run? As you see in the fluoro run, that with the recoil, the distal electrode has withdrawn slightly proximal to the bifurcating branch. Now, to have a 5 millimeter or less geographic miss is not advisable. So geographic miss should be more than 3 to 5 millimeter to be on the safety margin. Trying to get a total overlap entails risk of overlapping burn, which is at present not advisable. So now we'll start the second run. This time, as you see on the screen, the impedance of all 4 electrodes is within adequate limit. So as you see, when we had positioned the most proximal had a impedance which was slightly on the lower side. So I did rotate with my arm, the handle, the impedance which was around 305 ohms has gone up to 320 range, which is reasonably adequate. Patient is deeply sedated. So in deeply sedated patients, sometimes we may have some variability in impedance, but they are within reasonable limits. So now we have 4 electrodes in well contact in the mid to proximal artery. We have to avoid ostium. So Dr. Tejas Patel and Vipul Kapoor will initiate the second run of ablation. Please go ahead and start. So go ahead and start.
So starting the ablation, you will see on the monitor that the temperatures will slowly rise and the percentage is also depicted there, and the resistance in ohms electrode.
So as you see, slide movement automatically shuts off the electrode. And that is the whole computerized, as we call it, the AI.
So you can see the percentage rise, the depiction of fall here in the screen, on the screen, as well as the temperature rise on the right hand side. The resistance is more or less the same or slightly fallen. So that is the next ablation which is over now.
So here we got very good ablation contact in the distal mode electrode. The second electrode had partial ablation with some degree of loss of contact. The third electrode, the sensor in the console felt it had moved and discontinued and stopped. And the last electrode did ablate again to less degree. So now we have guided our wire into the inferior branch, which appears to be about 3 to 3.5 millimeter visual in size. And it's a very long branch. So very likely we'll be able to introduce all 4 electrodes inside that branch. Again, let's go to the CIMI run selective. We confirm the size visually of the branch. Let's go and show me the CIMI run. So as you see on the CIMI run, artery appears to be absolutely around 3 millimeters with some degree of 10-20% variability, and it's a long artery before it reaches the cortex. So we'll be able to, I think, adequately put the entire 2 millimeter of the 4 electrodes and the distal tip inside, where the tip can stay inside the cortex. Be liberal with the nitroglycerin. Give it liberally whenever patient is anyhow very hypertensive. We can see the cortex. So we can still advance the little bit to the catheter and then we'll pull back. Spiral catheter into the inferior large branch. We have placed it such a way that the distal electrode is about 4-5 millimeter, about 3 millimeter away from the cortex, parenchyma. However, when you see, despite giving nitroglycerin, the proximal electrode area shows some spasm, but probably it is more of a concertina effect which will not go away. So we will start now ablating in the distal 3 electrodes and switch off the 4 electrodes. If you see the electrodes resistance is very adequate for all 4 of them. So Dr. Tejas and Vipul will take over.
Right.
Please go ahead.
So as discussed, I will switch off the 4th channel, which you can see is now done. And now I can start the ablation.
Please. SCT has come out very adequate, around 600 plus. Stop.
So the ablation has started. The temperatures you can see are going up a bit, and the resistance is falling, especially with the second one, which shows about 12% reduction in the impedance.
Overall temperature is very steady between the range of 50 to 60. Once it starts going above 60, reaching 70, the machine will automatically shut off.
Seconds, 15 seconds more, 10 seconds more. We have a 14 to 15% reduction in the impedance, as you can see. And now 60 seconds are done.
So we have ablated this inferior branch except for the proximal segment where there was concertina effect and or some spasm. So we may pull back, introducing the wire. Again, pulling and pushing should always be with the wire support. So now we'll pull back and we'll keep one electrode here, pull back the wire again, see if we can properly place that one electrode only into the proximal segment of the inferior branch and make sure there is no overlapping effect also. So we have pulled back the wire and we'll do a small, very little dive, 1/4 cc. Fantastic.
Go down.
So we may advance little bit, but the concertina effect has gone away. The blood is flowing very nicely. So we will ablate that proximal 5 millimeter segment. Okay. Advance a little bit, record. And we have pulled back the wire again. Again we will check. So now we may be in the overlap area, so we may still pull back a little bit.
So we can switch off the second one, sir, and then we can still do.
No, the distal is in the overlap area. To get the perfect position of our second electrode, to make sure second electrode is beyond the carina but still proximal to the previously ablated area. So freeze here. Let's see 4 or 5 views earlier when we did the ablation in that scenario. As you see, the concertina effect or the spasm is gone away. So I think we are now in right position to the ablation of a single electrode number 2. Vipul,
Yes.
please go ahead. 60 seconds switch off first, third and fourth electrode. Experience of using this catheter over last few months across the world has made people realize that as many of unablated areas should be ablated instead of the original concept of ablating only 2, 3, 4 places.
High temperature. So as you can see now, the temperature has gone up to 66 and the machine has switched off the electrode on its own, which is the AI based safety feature of the machine, of the catheter.
As you see, some ablation took place, but again you have to understand this is the artery, there is some spastic component here which may be not obvious. So now we have pulled back the spiral catheter. We have pulled back the wire from the inferior branch. We advanced the wire into the main artery, into the distal branch, reposition the spiral catheter as you see in the runs, and we are now going to ablate Where originally the third electrode was switched off due to poor contact, now we've been able to get the second electrode touch, as you see in this run. So we will switch off the first, third and fourth electrode, right, Dr. Tejas and Vipul?
Yes.
Okay. So we will do a 1 minute run to cover that distal segment of renal artery before bifurcation. So we'll go ahead and switch off all the other 3 channels and do a selective run. So we have started. Looks okay. Temperature is 47, rising 48, 50, 51, 53. It's very steady around 60. And usually a good ablation takes place in 45 seconds. So let us hope we continue into 45 seconds before the AI decides to shut it off in case the temperature rises. So far we are fine, and I think we have done good ablation. We are now at close to 45 seconds, which is empirical cutoff mark. Excellent. Again, in some of these larger areas where there is a very high gush flow of blood, the cooling is slightly more, so the temperature rises less. So it does not mean you had a poor contact. So be careful and not to re-ablate in that same area again. It was a very successful one.
Right is done.
So right is done, and we do not need to do any more angiographic shoot or inject any dye. So now what we'll do is we'll pull back the wire into the guide, decannulate the left. Okay, fine.
Perfect.
So now we'll take a roadmap of the left renal artery to guide us for future ablation, upcoming ablation on the left side. The distal electrode is in the overlap area where we had ablated earlier with the proximal most electrode earlier. So now the distal electrode will be shut off and we will activate the second, third and fourth electrode, right?
Right. So I'm going ahead. Yes.
So we have a good impedance. Channel 1 is off and we'll start the burn. So we are done with the ablation. As you have seen, the second, third and fourth channel were activated. And you may wonder why in the fourth channel the temperature rise was not there, but it's time dependent. So since we were able to ablate for more than 45 seconds up to 60 seconds, even though the temperature did not go higher, it was still reasonably high at 42 degrees to create a reasonable burn in that area. Now we have replaced the catheter in such a way that to define the anatomy, there are 3 large inferior branches and 1 large superior branch. We have decided that in the 3 inferior branches, the distal one branch we would not ablate because it enters the cortex. The second branch we may ablate the proximal segment, but what we are doing now is we are ablating in the main renal artery between the 2 branches using a single distal most electrode. The electrode is well placed, impedance is good, so Dr. Vipul Kapoor will go ahead and ablate that.
So I'm switching off the second cord and the fourth electrodes, and we are just ablating the first channel, which is the distal most electrode. Okay. Right.
Antibiotic, please.
Yes, sir. Completely. You have been doing good.
So as you can see now on the screen, the ablation has started. Temperature rising to about 60 and impedance falling by about 10-11%. The wire is in the guiding catheter. The checklists have to be ensured. The electrode is well positioned, good contact, and the ablation is going on smoothly. The pressures presently are about 170/90. We started off with about 220 by 100. So there is some immediate fall in the blood pressures, but we would assess once the procedure is done.
Proximal segment of the inferior middle branch of the three branches. Again, when you have these branches which you are ablating, make sure your wire, whichever you are using, has double curve at the tip. So I had made initially a double curve, which is making it easier to go into the sharp branches. If you cannot, then you can also keep the spiral catheter in that area, pull back the wire, the distal tip marker of the spiral will drop into the branch and then advance the wire like we did once in the other renal artery. So we have repositioned the catheter in the middle inferior renal branch adequately with 3 electrodes inside that branch and the 4 electrode in the main renal artery. All 4 electrodes are in adequate position and missing the carina. So we have decided to go ahead and ablate in all those 4 areas. We will recheck and looks okay. So why we are okay now? We pull little bit the catheter. Ideally we should pull and push using the wire, but judicious pull back in a not heavily angulated and not abnormal anatomy. 2-3 millimeter pullback is adequate, but never push. So Dr. Vipul can now ablate all 4 points, 3 inside the inferior branch of the renal artery, the middle branch, and 1 inside right proximal to the carina with at least 4 millimeter margin from the carina.
Insufficient temperature.
So we are finding that the 4th electrode, which was at the borderline zone, they're showing insufficient temperature rise and automatically shut off. So we were debating earlier not to use that electrode. So the AI decided to agree with me. So my intelligence and AI intelligence coincided and it has shut off itself. The remaining 3 electrodes are doing very well. The innermost electrode is showing the higher temperature one, and the proximal one, the third one, is showing less temperature rise because there is a blood flow going there. So we are done there. The 4th electrode and the proximal most electrode did not function. So now we'll pull everything out in terms of the wire. First, let me get a good wire, make sure it doesn't get pulled back the catheter. Yeah, so that is what I mean.
Yes.
That was always the issue. Being a large artery, the angle was not conducive. So we'll position now into the main renal artery and make a decision whether to go into the superior artery and get it over first, which we can do. So we are now ablating with a single electrode into that superior branch.
High temperature.
So it's high temperature, it is shut off at about 27 seconds. and I think we'll not be pursuing that anymore. With the first and two, otherwise the distal two electrodes are in the right position and not overlapping the carina, so we'll go ahead and ablate them. Good resistance, good contact.
Okay.
Third and fourth are off.
Yes.
So we'll start. We abandoned earlier due to the heat and temperature, and I'll ask Dr. Vipul to re-ablate that area with slight repositioning with the electrode slightly proximal, hoping that the flow of the blood there will be able to keep the area cool enough. So let's start the ablation. We'll switch off the channel 2, 3 and 4. So again, it has gone up and it has auto shut off. So with this, we are very sure that we should not attempt any more in this area. It tends to get heated. And that may be because the artery size may be just right borderline. So we will now attempt one more in the inferior branch. So we have repositioned the catheter in the first of the inferior branches. Take a small squat. And looks very adequate, except that the proximal is slightly close, and we can shut that off and use the other 3 electrodes. The distal mode electrode is very close to the smallest part of the branch. So we have pulled back, and now we'll go ahead and ablate the distal 3 electrodes. Impedance looks good, contact looks good. We'll switch off the 4th electrode, which is the proximal one. Dr. Vipul, why don't you start the ablation with switching of the 4th electrode? Go ahead and start. Again, we are now ablating inside the proximal of the 3 inferior branches. Again, in the early Spyral or the early RDN catheter of Medtronic, which I was fortunate to do 4 cases, among the first in India in October 2013. We used to do very limited ablation, maybe single contact for ablation per artery. And as you see in today's case, I have not counted the total ablation. We are talking of reasonably very large number of ablations, which I will tell you at the end of the procedure. And that is where the original study did not show success against the sham trial, whereas the later study showed success, and subsequent experience of operators has led to very aggressive ablation of as many large branches as we can find. So we reposition the catheter so that the first and the 3rd electrode covers the unablated area. The 2nd electrode is right at the carina of the inferior branch which we just ablated, so that should be switched off. And the 4th proximal most electrode is right at the ostium, which should be switched off. And since the 1st and the 4th and the 3rd electrode are 5 millimeter apart, the 3rd electrode is in a very ideal position, 5 millimeter from the ostium. So I think we'll go ahead and do the last ablation.
Okay.
Pressure is dropped, flow is low. We have Dr. Niren Bhavsar. He is senior most director of our cardiac anesthesia department. He has been supervising the entire pain management. Pain management is an extremely important part of this procedure where pain management should be very adequately be done. The pressure which was running around 220 when we started the case is slowly declined to 150 systolic range. And during the ablation, it rises by about 10-20% even with the subconscious pain perception. This ablation seems to be going very well with adequate temperature rise, not over rise, and we are done. So we are done now, everybody. I will pull the catheter system out now and we'll do a check-in. Post-procedure angiography looks good, all the arteries are intact, no unusual areas.
Yeah, right.
Last blood pressure is around 180, but she's now awake with some degree of discomfort, back pain. We'll remove everything out and we'll use angiosil to close the 6 and side.